If you take Losartan, Amlodipine, Valsartan, or Metoprolol, there's a very real chance you've been told what the pill is called, what dose to take, and maybe what time to swallow it, but not the part that actually determines whether you stay safe on it. And that missing part is where people get hurt. They faint in the bathroom at night. They stop a medicine too fast and land in the hospital with chest pain. They ignore ankle swelling because they think it's just age, or they panic over a symptom that was never explained to them in the first place. I'm Dr. Eliza Wright, and if one of these medications is in your daily pill organizer, you need to stay with me. Because by the end of this video, you're going to understand 11 truths about these drugs that can protect your heart, your kidneys, your brain, and in some cases, your life. Before we begin, please subscribe to this channel for clear heart health guidance that protects your life, family, and peace daily. And let me be clear about something before we start counting down. When I say what doctors won't tell you, I don't mean your doctor is hiding the truth from you. I mean most appointments are rushed, the explanation gets compressed into 30 seconds, and the details that matter most at home are often the details patients never hear. These 4 medicines are common. Millions of people take them. But common does not mean simple. Each one lowers blood pressure in a different way. Each one creates different trade-offs. Each one sends a different signal about what your body may need. And the most dangerous mistake of all is assuming they're basically interchangeable, basically harmless, and basically fine as long as the number on your blood pressure machine looks better. That assumption is where people get into trouble. So let's start with truth number 11, because this one changes everything before the bottle is even opened. Truth number 11 is this: these are not 4 versions of the same pill. And that sounds obvious until you see how many people treat them like they are. I want you to think about Leonard, 72 years old, retired electrician, who told me, "Doctor, I've taken 3 blood pressure medicines over 10 years, and honestly, they all feel the same to me." He meant well, but that sentence told me he didn't understand his own treatment at all. Losartan and Valsartan belong to the ARB family. They work by blocking a hormone system that tightens blood vessels. Amlodipine is a calcium channel blocker. It relaxes blood vessels in a different way. Metoprolol is a beta blocker. It slows the heart and reduces how hard it works. Same goal, yes. Same road, no. And if you don't know which road your pill is taking, you can misread every side effect, every symptom, and every change your doctor makes from that point forward. That difference matters because the medicine you're on often tells a story about the body your doctor is trying to protect. If you're on Losartan or Valsartan, your doctor may be thinking not only about blood pressure, but also kidneys, heart failure risk, or long-term vessel protection. If you're on Amlodipine, they may want strong, steady blood vessel relaxation, especially if other medicines were not enough. If you're on Metoprolol, the story may not even be primarily blood pressure. It may be heart rate, angina, a prior heart attack, heart failure, or an irregular rhythm. Do you see why this matters? If you treat all 4 like interchangeable pressure-lowering pills, you miss the real purpose of the prescription. And once you miss the purpose, you start making dangerous decisions. You stop the wrong one. You complain about the wrong symptom. You assume the medicine failed when really it's doing exactly what it was chosen to do. And that takes us to truth number 10, which is more dangerous than most people realize. Truth number 10 is that Losartan and Valsartan are cousins, not teammates. Let me tell you about Rose. Rose was 69, organized, careful, deeply afraid of stroke because her older sister had one. Her primary doctor had her on Losartan. Then a hospital doctor, after a short stay for heart-related symptoms, changed her list and added Valsartan. Rose got home, looked at the bottles, noticed both were for blood pressure, and thought, well, more control must be better. So she kept taking both until her follow-up appointment 6 weeks later. By then, she felt washed out, dizzy, and strangely weak. She thought she was just tired, but what was happening inside her body was more serious. She was doubling up on the same medication family without understanding it. And because no one had fully explained that Losartan and Valsartan are both ARBs, she thought she was being extra careful when she was actually taking an unnecessary and potentially risky combination. This is one of those medication errors that happens quietly. Nobody wakes up and says, "Today, I'm going to stress my kidneys and push my pressure too low." It happens because the names sound different, the tablets look different, and patients are rarely told the class, only the brand or generic label. If you take Losartan, you should know Valsartan is from the same family. If you take Valsartan, you should know Losartan is not a backup pill you can throw in because you missed a dose yesterday or found an old bottle in the cabinet. These medicines can affect blood pressure, kidney function, and potassium balance. So any switch between them, any overlap, and any dose change has to be intentional and supervised. Not guessed, not improvised, not borrowed from a spouse. That's the hidden truth. The drug name is not the whole story. The family matters. And the next truth matters even more because it involves a side effect that terrifies people every day: swelling. Truth number 9 is that amlodipine can make your ankles swell, and that swelling can be so convincing it sends people into panic, denial, or both. Eleanor was 74. Always active, proud of the fact that she still walked every evening after dinner. Her doctor increased her amlodipine from 5 to 10 milligrams, and about 2 weeks later, she noticed her socks were leaving marks. Then her shoes felt tight. Then her ankles looked puffier by evening. She stared at them in the bathroom mirror and thought the worst. Was it heart failure? Kidney failure? Was something collapsing inside her body? Instead of calling, she did what frightened people often do. She watched. She worried. She cut down her walking because she felt uncertain. And over the next month, the swelling worsened. Here's the part nobody had explained to her. And this is what patients deserve to know from the start. Ankle swelling is one of the most common reasons people struggle with amlodipine, especially after dose increases. Now listen carefully because this point needs nuance. Swelling on amlodipine does not automatically mean something catastrophic is happening, but it also should never be ignored, especially if it's new, worsening, or paired with shortness of breath, chest discomfort, or rapid weight gain. The reason this side effect causes so much confusion is that it feels dramatic while often being medication-related rather than a sign that the medicine is poisoning you. Some people need a dose adjustment. Some need another medication added or substituted. Some do well once the dose changes. But what they should not do is silently suffer or assume swelling means the medication is wrong for everybody. Amlodipine helps many people beautifully. The hidden truth is simply that its most visible side effect often shows up in the feet and lower legs. And if no one warns you, you can lose weeks or months worrying about the wrong explanation. And that brings us to truth number 8, where people start blaming age for what may actually be a medication effect. Truth number 8 is that metoprolol can make you feel older than you are, slower than you are, and colder than you are. And many patients never connect the dots. Walter was 76 and came into clinic saying, "I think I'm just finally getting old." That sentence breaks my heart because sometimes it's true, but sometimes it's not true at all. Walter had been started on metoprolol after episodes of chest pressure and a racing heartbeat. Within a month, he felt tired in the mornings, less motivated in the afternoon, and annoyed that his hands seemed cold even in mild weather. He blamed retirement, sleep, weather, everything except the new pill. He thought he was losing energy because life was changing, but what he was experiencing may happen on beta blockers. Slower heart rate, lower drive, fatigue, and that strange sensation that your internal engine is idling lower than it used to. And here's the deeper truth. Metoprolol is not a bad medicine because it can do that. Sometimes that slower engine is exactly the protection the heart needs. That's why it can be so helpful after a heart attack, with certain rhythm problems, with heart failure, and with angina. But patients deserve to know the trade-off. If you suddenly feel unusually tired, weak, lightheaded, mentally flat, or you notice a pulse that seems much slower than normal, don't just shrug and say, "Well, I'm old." Don't silently accept it for 6 months. And if you have diabetes, this matters even more because metoprolol can blunt some of the warning sensations people rely on during low blood sugar, especially the pounding heartbeat that tells them something is wrong. So the hidden truth here is not that metoprolol is dangerous. The hidden truth is that its side effects are often misfiled as personality change, aging, winter, stress, or poor sleep, when in reality, they may be a medication signal that needs review. Truth number 7 is that the most dangerous days on these medicines are often not the ones years later. They're the first days after starting them, increasing them, combining them, or restarting them after inconsistency. Let me tell you about Martha, 81, who had her Valsartan dose increased after a run of high readings. She took the first higher dose after dinner, went to bed, woke up at 2 a.m. to use the bathroom, stood quickly in the dark, and hit the floor before she fully understood what was happening. She didn't break a hip, thank God, but she bruised her shoulder and terrified her family. When patients hear blood pressure medication, they think stroke prevention. They don't think about the hallway at night, the bathroom tile, the throw rug, the moment of standing. But that's where these medications meet real life. That's where dizziness becomes a fall. That's where a number on a bottle becomes a body on the floor. This is especially important for seniors because the body doesn't adjust to rapid shifts as gracefully as it did at 40. When a dose changes, your brain, blood vessels, and nervous system may need time to catch up. That doesn't mean the medication is wrong. It means you need a strategy. Stand up slowly. Sit on the edge of the bed for a moment before walking. Turn on the light. Hydrate appropriately if your doctor allows it. Know that dizziness, lightheadedness, and a faint feeling after dose increases are not symptoms to casually normalize. They are feedback. And if the problem keeps repeating, the answer is not stubbornness. The answer is communication. People get hurt because nobody tells them this part. They are warned about stroke in 10 years, but not about the next 3 nights. And what you haven't been told about those first days can be just as important as the long-term benefit. Now let's go to truth number 6, because this one shows up when you're sick, hot, sweating, and least able to think clearly. Truth number 6 is that dehydration changes everything. Harold, 70, got a stomach virus that most people would call just a bug. A day of vomiting, a day of diarrhea, not much appetite. He kept taking his Losartan exactly as prescribed because he was proud of never missing medication. He thought that was discipline. By day 2, he was weak, dizzy, and afraid to stand. His wife checked his blood pressure and it was far lower than usual. What happened? The medicine hadn't suddenly turned evil. The body around the medicine had changed. When you're losing fluid, not drinking well, sweating heavily in heat, or empty from illness, the blood pressure medication that normally fits your body may suddenly hit much harder. That's especially important with drugs like Losartan and Valsartan, which can interact with dehydration in ways that leave people lightheaded, faint, or feeling frighteningly unwell. This is one of the most important truths patients are rarely prepared for. The bottle instructions don't explain real life. They don't explain summer heat, food poisoning, a flu-like illness, or the week you can barely keep water down. But your body experiences those things whether the label mentions them or not. That's why every patient on these medications should know what I call the sick day conversation. Not a self-made rule. Not random stopping, a plan. What should you do if you're vomiting? What should you do if diarrhea lasts all day? What should you do if you can't eat, can't drink, and feel like your pressure is dropping through the floor? Those questions need answers before the illness happens, not during it. The hidden truth is that take daily sounds simple until your normal body is no longer your normal body. And if nobody has ever prepared you for that, you are vulnerable at exactly the moment you most need clarity. Truth number 5 is that over-the-counter medicines can quietly sabotage your prescription. And this is where so many careful patients get blindsided. Patricia was 73 and proud of how faithfully she took her blood pressure medicine. Same time every morning, same organizer, same notebook. Then winter came, along with knee pain from arthritis and a miserable head cold. She started taking an over-the-counter pain reliever for the knee and a cold remedy for congestion. Within 10 days, her blood pressure was higher, her ankles felt different, and she thought her prescription had stopped working. It hadn't. She had accidentally introduced new players into the game. NSAID pain relievers like ibuprofen or naproxen can interfere with blood pressure control and can be especially troublesome alongside medicines like Losartan or Valsartan. Cold products can contain ingredients that raise blood pressure. And because these are sold casually, people assume they're harmless companions. They're not always harmless. This is where patients need to become detectives. If your pressure suddenly rises, don't just stare at the prescription bottle and assume the problem lives there. Ask what else entered the picture. New pain pills, sinus tablets, decongestants, herbal products, someone else's leftover medication. Even natural supplements can muddy the water because natural does not mean tested, compatible, or safe with your prescriptions. And this is one reason I always tell patients, every time you buy something over the counter, pretend it's applying for a job inside your bloodstream. It should not be hired until it has been checked. The hidden truth isn't just that your prescription matters. It's that your prescription lives in an ecosystem. Everything around it changes how safe and effective it may be. And if you don't understand the ecosystem, you can be perfectly obedient to the main medication, while another pill on the shelf quietly undoes your hard work. Now we move to truth number 4, and this one can affect the heartbeat itself. Truth number 4 is that potassium can become a hidden danger when you take Losartan or Valsartan, and the most innocent-looking culprit is often the salt substitute in your kitchen. Dorothy was 67, recently told to cut sodium because of her blood pressure. She took that advice seriously. She stopped salting food. She bought a salt substitute marketed as heart-friendly. She felt proud every time she sprinkled it on vegetables because she believed she was helping both her pressure and her heart. What she didn't know was that many salt substitutes use potassium instead of sodium. And while that sounds healthy in theory, it can become a real problem if you're taking an ARB like Losartan or Valsartan. Those medications can increase potassium levels. Add supplements, salt substitutes, certain other medications, dehydration, or kidney issues, and suddenly you have a recipe for weakness, palpitations, muscle symptoms, and in severe cases, dangerous rhythm problems. This is one of the cruelest medication traps because it punishes people for trying to be good. They aren't abusing the drug, they're following lifestyle advice, just without the missing warning. So hear me clearly. If you take Losartan or Valsartan, do not assume all low-sodium products are safe for you. Do not assume a potassium supplement is harmless because it sits in the vitamin aisle. Do not assume muscle weakness, tingling, or an odd heartbeat is unrelated. Patients on ARBs often need periodic blood work for exactly this reason. Your doctor is not being fussy when they check kidney function and potassium. They're looking for the hidden side of a medicine that is helpful when balanced and dangerous when ignored. The truth most people never hear is that one of the biggest risks on these medications may not come from the prescription itself, but from the healthy thing added beside it. And that leads us to truth number 3. Which changes how you think about being on more than one blood pressure drug. Truth number 3 is that needing 2 or 3 blood pressure medications does not mean you have failed. Clarence was 71 and almost ashamed when he told me he'd been prescribed amlodipine on top of Valsartan. A few months later, a diuretic was discussed, and he looked at me like he was receiving a moral verdict. "I guess I really messed up somewhere," he said. That belief is so common and so destructive. People hear another medication and think their body is broken, their lifestyle must have been terrible, or the doctor is guessing. But high blood pressure often requires combination treatment because the body has more than one pathway keeping that pressure elevated. One medicine may relax vessels, another may block a hormone signal, another may reduce fluid burden. Used carefully together, these are not signs of defeat. They are signs of strategy. And for many people, combination therapy works better and more smoothly than endlessly pushing one medicine higher and higher. Now, that doesn't mean every combination is automatically right. It means you should stop interpreting multiple medications as proof that disaster is near. Many patients are controlled because the right combination addresses the problem from more than one angle. In fact, some of the most effective long-term regimens include an ARB, a calcium channel blocker like amlodipine, and sometimes a diuretic when needed. The hidden truth here is emotional, not just medical. Shame makes patients hide things. Shame makes them skip doses and not admit it. Shame makes them resent a treatment plan that may actually be protecting them. If you're on 2 medicines, that is not a confession. If you're on 3, that is not proof you've done life wrong. The question is not, how many pills am I on? The question is, do I understand why each one is here? And that question becomes critical in truth number 2, because this is the medicine people misunderstand more than any other on our list. Truth number 2 is that metoprolol is often not prescribed just because your blood pressure is high. And if nobody has ever explained the real reason you're on it, you are flying blind. Samuel was 68, and he came in frustrated because he'd read online that beta blockers weren't always the first choice for ordinary hypertension. He looked at his medication list and assumed he had been treated incorrectly for years. But Samuel's case had a detail he'd forgotten to connect: episodes of chest tightness and a fast rhythm years earlier. His metoprolol wasn't just there to lower a number. It was there to slow the heart, reduce workload, and help protect him from symptoms that mattered just as much as the blood pressure reading. This is why internet comparisons can be dangerous when they lack context. Amlodipine, Losartan, Valsartan, Metoprolol, they are not competing in a beauty contest. They are answering different clinical questions in different bodies. So if you are on metoprolol, do not make the mistake of hearing that it's not first line for simple blood pressure, and then deciding it must not belong in your life. Ask the better question: why was it chosen for me? Prior heart attack, angina, irregular heartbeat, heart failure, tremor, fast pulse, anxiety-related surges? The same pill means different things in different patients. And that's exactly why blind comparison is dangerous. The hidden truth is not that metoprolol is overused in every case. The hidden truth is that patients are often never told what specific job it is doing in their body. Once they miss that explanation, they start judging the drug by headlines rather than by purpose. And if they do that, the final truth, truth number 1, becomes terrifyingly easy to commit. Because if you don't understand why a medicine is there, you are much more likely to stop it suddenly when you feel fine. And that, for some people, is the most dangerous decision of all. Truth number 1 is this: feeling better is not permission to stop these medications on your own. And with metoprolol especially, stopping suddenly can be dangerous. Let me tell you about Irene's husband, David, because his story still stays with me. David was 75, sharp, independent, hated the feeling of being on too many pills. He had been taking metoprolol for years. One week, he felt especially tired, looked at his bottle, and decided to take a break for a few days to prove he didn't need it. He didn't call, he didn't taper, He didn't ask. On the second day off, his heart began pounding. He felt chest pressure, and he ended up in the emergency room scared out of his mind. That is what patients are not told often enough. Some blood pressure medicines are not just quiet number lowerers. They become part of the rhythm your body has adapted to. Remove them abruptly, and the rebound can be ugly. And this applies beyond metoprolol too, even if metoprolol is the one I worry about most for sudden withdrawal. Losartan, Valsartan, Amlodipine, these are long-term control medicines. They manage a silent condition that usually does not send warning pain before damage accumulates. So when a patient says, "I feel normal, maybe I don't need it anymore," they are misunderstanding the entire victory. You feel normal because the treatment may be working. High blood pressure is called silent for a reason. It does not sit on your shoulder all day reminding you it's there. That's why inconsistency is so dangerous. Skipping during travel, doubling the next day, taking it when pressure seems high, stopping for a week because you want to cleanse your body. The hidden truth most doctors don't have time to say slowly enough is this: blood pressure medicine only protects you when you treat it like a system, not a mood. And the moment you start freestyle dosing, you replace protection with chaos. So let me bring all of this together in the way I wish every patient heard it the first day the prescription was written. If you take Losartan or Valsartan, know that kidney function, hydration, potassium, and salt substitutes matter. If you take amlodipine, watch for swelling, dizziness, flushing, and don't silently endure symptoms that should be reviewed. If you take metoprolol, understand that tiredness, cold hands, slow pulse, and sometimes masked low sugar warnings can be part of the picture, and never stop it abruptly without guidance. If your dose changes, be extra careful standing up, especially at night. If you get sick with vomiting, diarrhea, or poor intake, know that your medication plan may need review. If you buy pain relievers, cold remedies, supplements, or low-sodium products, check them first. And above all, ask your doctor or pharmacist one question every patient deserves to ask. What exact job is this medicine doing in my body? That one question changes everything, because it turns blind obedience into informed safety. And I want to leave you with one final image. Somewhere tonight, a senior is opening a pill box and swallowing a tablet they don't fully understand. Maybe it's Losartan, maybe it's Valsartan, maybe Amlodipine, maybe Metoprolol. Maybe they've been taking it for 10 years and still couldn't tell you why it was chosen, what side effect matters, or what symptom should prompt a call. That is not their fault. But after this video, it doesn't have to stay that way. You do not need to become a cardiologist overnight. You just need to stop being a stranger to your own treatment. Know the family, know the purpose, know the side effects that matter, know what not to mix in casually, know what never to stop suddenly. Because when you understand your medication, fear goes down, safety goes up, and your doctor can finally work with a patient who sees the full picture. Not just the pill. Take care of yourself, protect that heart, and I'll see you in the next video.